शायद कितना 3 मिनट है ना, कितने 3 मिनट है, 2 मिनट, 2 मिनट रुके या रुकना है ना। हेलो, हाँ नरेंद्र, आपका फ़ोन है? हाँ, गुड मॉर्निंग दीदी। तो आप रोहित से बात कर रहे हैं? मैं तो हॉस्पिटल में हूँ ऑलरेडी। एक सेकंड, क्या बोल रहे हैं?
अभी आप ऑनलाइन है?
ऑनलाइन स्टार्ट कर सकते हैं। हेलो, हाँ ठीक है, टेस्ट करा लीजिए। आप तो आ नहीं रहे, 3 दिन 4 दिन से वही आ रहा है, तो आज ही तो बुखार आ गया। हाँ, फ्राइडे सैटरडे संडे 3 दिन से तो आप घर पर ही हैं। नहीं, मैं तो आप नहीं आए थे, रोहित नहीं आया था, मैं आई थी सैटरडे। मैं भी सुबह 7 बजे अभी हॉस्पिटल में हूँ। हाँ हाँ, हाँ मैं वेडनेसडे तो मैंने छुट्टी ली थी, थर्सडे में कुछ काम था। रेगुलर क्या, हफ्ते में 1 ही 2 दिन आते हैं रेगुलर में। हाँ चलिए ठीक है, कोई बात नहीं, आज आप टेस्ट करा लीजिए। और रोहित को, जी हाँ, आप रोहित को सडनली, आपको सब चीज़ सडनली, मुझे समझ नहीं आता सडनली कैसे हो जाती है। नहीं नहीं, पर फीवर आपको कल से महसूस हो रहा होगा, तो रात को आपको उसको इन्फॉर्म करना चाहिए था रोहित को कि मेरी तबीयत ठीक नहीं लग रही है। अच्छा, तो अभी आपने उसको बता दीजिए दोबारा। मैं तो हॉस्पिटल में ही हूँ, अभी सुबह मेरी क्लास थी, मैं आ गई 7 बजे। नहीं, अभी कहाँ बाहर होगा सुबह सुबह 7 बजे। हाँ, ट्राई नहीं, उसको बोलिए कि मैडम हॉस्पिटल में ही है ऑलरेडी, आप टाइम पर हॉस्पिटल आ जाएं। थोड़ा लेट चलेगा लेकिन आ जाएं, उसको अभी बता दीजिए। स्टार्ट करेंगे। Good morning everyone. So today we are going to talk about, it's not shown on the screen, screen में नहीं आएगा तो वो कैसे देखेगी? सो लेक्चर तो मैं यहाँ तो आई हूँ, पर आई डोंट नो इट्स ऑनलाइन। आ गए हैं, अच्छा, ओके ओके ओके। So the outline of my presentation will be, we'll be discussing about the mechanism of twinning, let us see what is Helen's law. It is the principle 1 in about 89 pregnancies end up in birth of twin. So among all the twins, 70% of the twins are dizygotic and 30% of them are monozygotic. And the most important thing in twins is to understand the zygosity and the chorionicity. Now, what is the mechanism of twinning? So, mostly all dizygotic twins are fertilization of the two ova by two sperms, and all the monozygotic twins are the source of embryo is same, and then the splitting of that embryo takes, and the splitting of the embryo at various time decides what is the fate of that twin is going to be. So if the splitting occurs within 0 to 4 days, early splitting, it becomes the dizygotic diamniotic. If it is between the 4 and 8 days, they are still diamniotic but monochorionic, they have single placenta, and beyond 12 days they have joint monoamniotic and monochorionic twinning, and if it occurs later, it leads to conjoined twinning. So overall incidence of diamniotic monochorionic is about 65%, monoamniotic monochorionic is about 5%, and the conjoined twinning is less than 0.5%. Now the twins, the incidence is rising alarmingly, and there has been 77% increase in twins, 4 times increase in triplets since 1980 to 2003 because of the advent of ART. 26% twins are there because of ovulation induction, 5% with clomiphene, and 60 to 40% twinning happens if we use gonadotropins. The use of ovulation inducing agents leads to multiple ovulation and superovulation, which results in the incidence of twinning, and this is the reason these days we see that lot of twins are being born. Now, what are the risk factors with twins? Why are we worried with multiple pregnancy? Now, the risk factor is race. So there is an ethnic and racial variation, as we see that the highest twinning rate in Nigeria and lowest in Japan. There is a hereditary history. If the mother has a twin, then the chances of having a twin in the child is increased. It is also associated with advancing maternal age. Why? Because when the maternal age increases, the FSH increases with age and it peaks at 37 years. So when the high FSH leads to multiple ovulation and it leads to multiple pregnancy. Now parity, gestational order 5 and more, there is 20-fold increase. So higher order multiparity is associated with 20-fold increase in twinning. The oral contraceptive use results in increase in FSH rebound, and that may lead into twin pregnancy. Now monozygotic twinning is relatively constant, 1:250 regardless of maternal age, race, parity. It is not dependent on ovulation, hereditary, although it can play a role. 2 to 12% increase with advent of assisted reproductive technology. Now, why management differs from singleton? Why are we discussing multiple pregnancy as across singleton pregnancy? So, there is a difference in the management, fetal versus maternal, and we will study each of them separately. Now, in first trimester, the abortion rates are quite high. It is increased more in monochorionic and those who are conceived through ART techniques. There is an excessive nausea, vomiting because of very high serum beta HCG. The plasma volume increases according to the fetal number, and the plasma expansion is greater in average is 50 to 60%, predisposing all these pregnancy to anemia and the risk of hydramnios, which can result into obstructive uropathy. In second trimester, the incidence of preeclampsia and gestational hypertension because of anti-angiogenic soluble tyrosine kinase 1, decrease in pro-angiogenic PIGF levels. So there is about 12 to 20% increase in PIH as compared to 10% in singleton. Increase in gestational diabetes, it is the exact incidence is not known, but maybe it is because of larger placenta and larger anti-insulin placental hormones leading to gestational diabetes. Higher incidence of preterm birth because of uterine stretch, which results in CRH, decreases in placental progesterone. So 60% of the twins are birthed preterm, 90% in the triplets, and virtually all quadruplets are delivered preterm. Placental abruption incidence is very high. In singleton it is 1 in 200. However, in twins it is twice as high as compared to singleton. Placenta previa, because of larger placental mass, it is further increased in ART pregnancy and because of increasing age and parity. In singleton, placenta previa incidence is 1 in 300. However, it is 40% more in case of twins and multiple. The incidence of acute fatty liver of pregnancy is 14-fold increased in twins. Postpartum hemorrhage, intrahepatic cholestasis of pregnancy is also very higher as compared to singleton. Now, management algorithm for multiple pregnancy is obviously information, support, nutritional advice, and specifically determination of chorionicity, and depending upon the chorionicity, monitoring of specific complications, which we will discuss subsequently. Now, nutrition, as we all know, that the calorie intake is about 3000 kilocalorie per day in normal. In pre-pregnancy, 40 to 45 kilocalorie per kg per day. The need for iron is twofold that of singleton. As in singleton, we know the daily requirement is 100 milligram of elemental iron, but in twins it is 200 milligram and 1 milligram of folic acid. The calcium intake is also doubled, and in postpartum we need excessive maternal calorie intake because of the lactation. Now, why do we need to do an early ultrasound between 11 to 13 weeks? It is a must because you can do accurate dating. We can look at the number of gestational sacs and fetuses. We can determine the chorionicity. This is the single most important factor for an early ultrasound. We can look at the lambda sign, which is a pathognomonic of DADC twin, and a T sign, which is pathognomonic of a DAMC twin. I'll tell you in the pictures. We can also measure the nuchal translucency, which is the most accurate aneuploidy screening method in twins, and we can also look at the vanishing twin, which is a spontaneous reduction of one embryo or fetus of a twin pregnancy, which is about 20 to 40%. Now, in early ultrasound chorionicity, risk of complication varies with chorionicity. As I said, that monochorionic twins are at higher risk as compared to dichorionic, and it is best identified before 14 weeks of ultrasound if you do. Now, how do we look at, I was talking about the lambda sign. So, lambda sign is when you look at the chorionic plate and you see that in between the intertwin membrane, if you are able to see the chorionic plate going within the membrane, which is known as the lambda sign, and that is indicative of DADC twin. That means there are two placenta and two amniotic cavities. So, if you see the lambda sign, it is dichorionic twin pregnancy. But if you look at the T sign means when you look at the intertwin membrane, which is very thin, and you don't see any chorionic plate projecting within the twin membrane, it is a T sign, and that is indicative of the dichorionic pregnancies. Now, screening and management of fetal complications, chorionicity is the most important, single most important factor. Now we can look at the screen, we can screen for specific structural malformation, and we can look at the screening for aneuploidy and then specific unique complication. Now structural anomaly in dichorionic, risk of each fetus is same as in singleton because they are two ideal identities. There are no sharing of the blood supply, there are two amniotic cavity, two placenta, so risk for independent each fetus is singleton as to compared to the singleton. However, if there is a monochorionic, the risk becomes 3 times higher as compared to singleton because of the unequal distribution of cell mass or cleavages, and also the vascular events happening in early embryogenesis, as in there is vascular anastomosis happening in the placental plate, and because of that they are highly predisposed to different complication which we will discuss later on. Now structural anomaly screening which we do in early 14 weeks, we can look at the neural tube defects, brain lesions, facial clefts, gastrointestinal defects, anterior abdominal wall defects, cardiac anomalies, and as in these all the anomalies are higher as compared to singleton pregnancy. A detailed fetal echocardiography is also indicated between 18 to 22 weeks to recognize the cardiac defects in these babies. Now aneuploidy screening. Zygosity is more important than chorionicity in aneuploidy screening, and monochorionic are we have to understand one thing, the dichorionic and diamniotic twins they are also known as non-identical twins. So if you and they are can be of different sex because they are the result of separate fertilization of 2 eggs with 2 sperms. But if there are monochorionic twins, they are known as identical twins. So if you see they are of the similar sex because it is due to splitting of the same embryos. So this basic fact you have to understand that between the monochorionic and the dichorionic amniotic twins. Now in monozygotic twinning, each fetus is at similar risk as of singleton. However, in dizygotic, each fetus has an independent risk and fetus specific risk is there. So the only way in early pregnancy we can look at the aneuploidy screening is by nuchal translucency. That is the most important screening tool we have because the biochemical screening is not very accurate for multiple pregnancy. Now this is the algorithm for aneuploidy screening. We can look at the nuchal translucency measurement combined with the maternal age. This has been the method of choice. First trimester serum screening and nuchal translucency over the maternal age. Now what we follow is that integrated sequential screening with nuchal translucency plus first and second trimester cord screening, and we also look at the level 2 anomaly scan, which has been a very specific screening tool in the case of multiple screening. For higher order multiples like triplets, only nuchal translucency and maternal age. Non-invasive prenatal testing should not be offered to multiple pregnancies now because it has been mostly the guidelines. Now what should we do for aneuploidy? At your level, I think you have to understand that nuchal translucency and the maternal age, and here at AIIMS we follow the combined screening for multiple pregnancy. Triple screen is offered if they come late for booking because there is very high false positive rate as we have explained. So they come early, we look at maternal age and nuchal translucency. Now what about invasive prenatal testing? If the nuchal translucency comes abnormal or if the mother is of advanced maternal age, should we offer them invasive prenatal testing? And what test? So CVS or amniocentesis. CVS has an advantage because you can do earlier identification and thus you can do a selective termination specifically if that fetus is abnormal, and risk, however, the risk of fetal loss amnio versus CVS is 2.5 versus 1.5. Should we sample one or both twins? both fetuses to be sampled if we are doing a aneuploidy testing. So if we are doing invasive testing for twins, CVS, one sac we can sample transcervically, another we can simultaneously do abdominally, which can prevent the mix-up. If we are doing abdominally, then we can selectively select the 2 puncture sites. We can inject indigo-carmine, and then we can take out the amniotic fluid sampling, and we can know whether we are sampling the same sac or the different sac looking at the color of the amniotic fluid. Now one puncture technique is also the sample is taken for the first sac and the needle is advanced with ultrasound guidance through the membrane into the second twin. But here disadvantages is you can iatrogenic create monoamnioticity because you are puncturing the amniotic membrane sometimes. Now common fetal complications are growth discordancy, preterm birth and single intrauterine fetal demise. We will discuss each one. Growth discordancy. 15% of the all twin pregnancies may have growth discordancy. How we diagnose is if you see that the abdominal circumference that there is difference of more than 20 millimeters and the expected fetal weight discordancy is more than 25%, then we say that the fetuses are growth discordant. Now in dizygotic twins, it is because of sometimes crowding, discordant anomalies and different genetic growth potential they may be discordant, but in monozygotic it is more common because of unequal blastomere allocation and the vascular anastomosis leading to differential nutrition and the blood supply to the twins. So the growth discordancy is, if we see it is quite pathognomonic of sometimes monozygotic twins. Now difference between TTTS and growth discordance. If you see the growth discordant fetus, how will you say whether there is twin to twin transfusion syndrome or they are just discordant growth? In TTTS you will find hydramnios or sometimes a Stuck's twin. However, in discordant growth, normal amniotic fluid and you will see it is less than 8 centimeter as compared to in TTTS, which is generally severe polyhydramnios. Now in selective IUGR you will see that 10 to 15% of monochorionic twins develop selective IUGR. There is unequal placental sharing and the large aorto arterial anastomosis plays an important role. Now the second condition which comes, which you have to learn, is single intrauterine fetal demise. Now the intrauterine fetal demise, if it happens very early before 11 weeks, is like it is a vanishing twin. It doesn't affect the surviving twin at all. So early pregnancy loss is like vanishing twin in 20% of the twins and 40 to 50% of higher order multiple birth. They vanish before 12 weeks. And the prognosis of co-twin is better with very early loss. The surviving twin does very good. But what happens if there is a demise after second trimester, it is after 20 or 22 weeks, then the risk of death of one twin increases the death of another co-twin. In DAMC twin, it is 2.5% more than DADC twins. And the risk, why? Because in DADC the surviving twin does not have the common placental supply, so it doesn't affect, but in monochorionic there is increased risk of complication, which we will discuss subsequently. Now what happens in single intrauterine fetal demise? In monochorionic, it is generally because of TTTS or selective IUGR or discordant fetal anomalies or traps in sequence or sometimes after laser coagulation. Now complications, death of a co-twin. The odds of death is 6 times higher in monochorionic after 20 weeks compared to dichorionic. Neurological sequelae can happen in surviving twin in 26% in monochorionic. Why? The cause is because of thromboplastin theory. There is passage of thrombotic material from the dead fetus going into the surviving fetus, leading to neurological sequelae in the surviving twin. So you have to counsel the parents. And the ischemic theory is because of the sudden hypotension, it causes flow from the surviving twin, leading to ischemic injury in the surviving twin. So there may be porencephaly, multicystic encephalomalacia, and cerebral palsy, etc. These complications may happen in the surviving twin, and there is risk of preterm delivery. Now, single intrauterine fetal demise management, which is very important. If the death of one twin happens, you have to give antenatal steroid cover and magnesium sulfate for neuroprotection. In DADC, you can delay up to 34 weeks, maximum up to 37 weeks. But in case of monochorionic twins, you have to do serial ultrasound, you have to do MRI after 3 weeks, and if you see there is no neurological damage, you can prolong the pregnancy up to 34 weeks. But in monoamniotic monochorionic, if it is less than 28 weeks, you have to do intensive monitoring, take it to 28 weeks and deliver, because survival less than 28 weeks is very bleak. So you have to monitor them up to 28 weeks and then you should deliver. You should not wait until 34 weeks in case of monoamniotic monochorionic. Single intrauterine device per se is not an indication for cesarean section. However, if you have to deliver cesarean, it is because of the obstetric indication. If it is malpresentation, if the leading live twin is very severely growth restricted, and if you see that the presenting twin is dead and there is monoamniotic monochorionic twinning. Now, preterm birth is a very, very important complication of multiple pregnancy. So, although most of the intervention which are described have not proven the evidence base, like giving bed rest, home uterine monitoring, tocolytic therapy, 17-hydroxyprogesterone, vaginal progesterone, and prophylactic cerclage and vaginal pessary have not shown to progress the duration of pregnancy. Now, unique fetal complications which can happen in monochorionic twinning is the perinatal mortality of monochorionic twin is nearly twice as high as dichorionic twins. The twin-to-twin transfusion syndrome, TAPS, TRAP sequence, and selective IUGR is very, very common in monochorionic twins, and we'll quickly discuss. Why this complication happens, I told you earlier, it is because of the abnormal sharing or the abnormal vascular anastomosis in monochorionic placenta. These vascular complication happens. Twin-to-twin transfusion syndrome, or twin reverse arterial perfusion, or twin anemia polycythemia sequence. The most common of these complication is TTTS, and which at your level is sufficient to understand. In 10 to 15% of the monochorionic twins, they usually present between 16 to 26 weeks. And when should you suspect? Because if it is unidirectional unbalanced flow due to deep arteriovenous anastomosis between donor and the recipient twins. The donor becomes anemic and growth restricted because it is diverting its blood flow to the recipient. And the recipient, because of excessive blood flow, becomes polycythemic, hydramnios, plethoric, hyperbilirubinemia, and vasoocclusion. Now, what happens in TTTS? There are different stages of TTTS, I will tell you. Now, in this picture, you can see what is happening. In the recipient twin, there is polyhydramnios. So, because of the overextension, the stretching of the amniotic cavity, they are at the risk of preterm birth. But and also because of hypervolemia, hypertension, they are because of the overflow heart insufficiency, or they are at the risk of developing polyhydramnios, pleural effusion, etc. Now there are different stages of TTTS, which is the staging which is known as Quintero staging, which is based on ultrasound and Doppler. In stage 1 there is very small difference in the discordant amniotic fluid. Urine is still visible. We look at the bladder and you see in the donor you can still see the bladder, which is known as Ollie-Poly sequence. The twin is Ollie-Poly sequence. Stage 2 is when you can't see, the bladder is not visible within the donor bladder, and however the Dopplers are still normal. In stage 3 it is the abnormal Dopplers you find in the umbilical artery, ductus venosus and umbilical vein, and stage 4 you see frank hydrops in either of the twin, and stage 5 is demise of either fetus. Now, how do we manage? Early diagnosis, if we do ultrasound at the late second trimester between 18 to 22 weeks, you will be able to diagnose. And if you have done an early ultrasound and if you have diagnosed chorionicity, then you will keep this pregnancy under very close surveillance, because you know that the babies may develop TTTS. Usually a serial AFI and bladder shadow in both the twins every 2 weeks starting from 16 weeks. That is the first stage when you see Ollie-Poly and the bladder shadow, and you can explain the risk to the parents. Neurological damage 6 to 26% depending upon the intervention, and in stage 3 TTTS the perinatal loss is to the tune of 70 to 100% without intervention. So you have to refer these pregnancy to higher center for laser ablation or radiofrequency ablation for timely intervention. So in all TTTS beyond stage 2, 3, 4, laser ablation is the treatment of choice. So what do you do in laser ablation? You basically try to intervene where you see the anastomosis, and under ultrasound guidance a probe is passed, radiofrequency probe is passed, and then you try to ablate, radiofrequency ablation of these anastomotic vessels is done. So ultrasound guided 18 to 20 gauge needle insertion into the recipient sac. What it does, that you drain some of the amniotic fluid from the polyhydramnios twin sac. It will reduce the pressure, improve the placental circulation and perfusion, which is a temporary effect, and then you can fetoscopic laser ablation for vascular anastomosis. This is the highly effective treatment for monochorionic twinning. This is a placenta where you can see that, which was delivered late, the baby delivered later, you can see that it underwent a laser ablation for TTTS. This is how it looks, that you have ablated the vascular anastomosis. Now the second complication is twin anemia polycythemia sequence. This is there is no discrepancy between the amniotic fluid. However, there is discrepancy between the donor and the recipient twins in significant hemoglobin differences. We can diagnose by monitoring MCA-PSV, and intrauterine transfusion treatment can be given if the hemoglobin difference is very high. You can look at the MCA-PSV, and if the peak systolic velocity in the middle cerebral artery is very high, which happens in the fetus because of brain sparing effect if the fetus is severely anemic, and the other one, if you see MCA-PSV is normal, and then we can look at we can take the cord blood sampling in the patients where you see the serial differences, and then you can transfuse intrauterine transfusion in the severely anemic baby if the hemoglobin difference is high. So anemia in donor, if you see MCA-PSV difference of more than 1.5 MOM. The twin reverse arterial perfusion, this condition is because of the acardiac twin in 1% of the monochorionic twins and approximately 1 in 35,000 birth. If the size of the recipient is more than 75% of the donor, the chances of cardiac failure happens in about 30% of the fetuses. Now, this is a diagrammatic description how it happens. The arterial perfusion pressure of the donor twin exceeds that of the recipient twin, which receives the reverse blood flow of deoxygenated arterial blood from the donor, and there is no heart to pump towards the head. So there it preferentially goes to the limb, and there is disruptive development of the upper part. So the other twin becomes a ghost twin, or it doesn't have a heart, and there is acardiac or acephalous failure of the head growth in the other twin. This is the acardiac myelocephalus, where the abnormal development of the recipient twin is happening. Now, the diagnosis is you can look at the Doppler and you look at arterial anastomosis for reverse flow towards the acardiac twin, and you can diagnose. How do you manage the trap pregnancies? You have to deliver them if more than 16 weeks, then umbilical cord bipolar coagulation or a radio frequency ablation or an intrafetal laser therapy, if available, is the treatment of choice. This is a bipolar forceps which is introduced under ultrasound guidance, and we sever the acardiac monster twin from the normal fetus. Now, monoamniotic pregnancies. The diagnosis of monochorionic, as I said, that you have to do an early ultrasound, and when you look at this ultrasound in this picture, you will see that there is a single yolk sac. The yolk sac, and there are two fetal poles. So if you see this condition, then you know that they are monoamniotic, the single amniotic cavity, and they are monochorionic. So if they are monochorionic, monoamniotic, the specific complication in this can happen cord entanglement, knotting of the cord can happen, and they can lead to some complication which are unique to MAMC twins. The congenital anomalies are very high, especially cardiac anomalies, and mortality rate in MAMC twin is to the rate of 20%. The management of MAMC twin is you have to do an early ultrasound like in all twin pregnancy, early identification, detailed anomaly scan, which we already do in all kind of pregnancy, multiple pregnancy, a fetal echo. We have to admit them between 20 to 26 weeks, give them antenatal steroid, do biophysical profile at least twice a week, monitor them for TTTS 2 weekly, and then we have to look for cord entanglement. Although it's not an acute event, sometimes maybe subacute, it can be monitored and delivered by cesarean section, preferably up to 34 weeks. But if there is any complications, earlier intervention, because we are giving anyway the antenatal steroid, up to 32 weeks also we terminate. We cannot deliver them MAMC, we have to do a cesarean section for all these twins. Now, conjoint twinning, as I have already told you, that if the splitting of the monochorionic twinning happens beyond 12 days, then the conjoint, there are joint twins, and it happen 1 in every 50,000. It's a rare event, but we do see these conjoint twins happening, and they can be also diagnosed by doing ultrasound. These are some of the ultrasound pictures, and then you have to do a detailed fetal MRI to find which are the organs sharing between the conjoint twins. Depending on that, the prognosis is explained to the fetus, the parents. Now, in all twin pregnancy, in the monochorionic twin pregnancy, we start monitoring them from 18 weeks. We start doing ultrasound 2 weeks because of increased complications of TTTS. We look at the AFI and bladder shadow, and growth once in 4 weeks growth scan is done. In dichorionic pregnancy, they can be monitored 4 weekly starting from the anomaly scan like we do in the singleton pregnancy. The uterine artery Doppler not to be offered in uncomplicated pregnancies, but all complicated monochorionic pregnancy you have to do. Fetal echo in all monochorionic at between 18 to 22 weeks, and in all multiple pregnancy antenatal visits every 2 weeks starting from 28 weeks. NST monitoring in uncomplicated DADC twin starting from 34 weeks once a week, and in monochorionic twinning starting from 32 weeks once a week. So the monitoring is started early in monochorionic, and dichorionic you can monitor them weekly from 34 weeks. Labor and delivery and their timing. According to different guidelines, if you broadly understand the fetal lung maturity happens 2 weeks earlier in multiple pregnancy, twin pregnancy as compared to singleton. So for a twin, term gestation is 37 weeks is considered 37 to 38 weeks as compared to 40 weeks in singleton pregnancy. So with all if there is everything normal, so in DADC twin by all guidelines we say 37 weeks is an appropriate time to terminate them, and prolonging twin gestation beyond 38 weeks increases the risk of fetal death, so we never go beyond 38 weeks. And in all triplets we know they cannot be delivered vaginally, so we offer cesarean section, but in twins you need labor and delivery, you need skilled obstetrician, anesthesia team, pediatric team, you need 2 pediatrician, IV access have to be established, blood for cross matching grouping, and you need 2 double CTG machine. Now you have to look at, when we look at the do a pelvic assessment or when we do an ultrasound, we have to see the presentation of the first twin. So if first twin is cephalic, then you can look at the second twin. If the first twin is cephalic, you can give them trial for vaginal delivery. But if the first twin is non-vertex, you have to deliver them by cesarean section. So the indication of elective cesarean section in twin pregnancy is all monochorionic monoamniotic twins, conjoined twins, and high order gestation like triplets and higher order have to be delivered by cesarean section. Now what is the protocol for labor and delivery? So if the first twin is cephalic, you can give them trial of labor with the facility for emergency cesarean section available. So after delivering the first twin, if the second twin is cephalic, you can deliver them vaginally safely, the second also. But if the second twin is non-vertex like breech, you can do a breech extraction, or you can do external cephalic version intrapartum and convert them into a cephalic. And in cases where you are not able to do and there is drop, there is cord prolapse, there is placental abruption, or there is severe bradycardia, you have to do sometimes a second stage cesarean section for emergency section for the second twin. So as I already discussed, labor analgesia, we can do epidural. The advantage of extension if in the intrapudalic version is needed, if you have already given them epidural. Delivery of second twin, do not give prophylactic methogen after the delivery of the first baby, you have to remember this. Continuous CTG, check for cord pulsation. Start oxytocin if contractions are not effective after the delivery of first twin. If you see the contractions are waning, then you start oxytocin. You can do a gentle fundal pressure and rupture of membrane, and 30 minutes twin to twin delivery interval is best for perinatal outcome. So if the baby is not delivered within 30 minutes, you have to intervene. In special circumstances, The lie of second twin is made longitudinal by external or internal cephalic version if it is not longitudinal. Planned emergency LSCS if there is persisting malpresentation, cord prolapse, placental abruption or fetal distress, or the cervix is closing. These are the indication where you might have to convert the vaginal delivery into an emergency cesarean section. Indication for internal podalic version in modern obstetrics exclusively in second stage of labor in conjunction with breech extraction to effect the delivery of a second twin with a persistent transverse or oblique lie is still justified. Now in third stage there is active management of third stage of labor. Oxytocin infusion is continued for 3 to 4 hours post delivery. Why? There is very high incidence of atonic PPH because of over distension of the uterus due to multiple pregnancy, and because of larger placental volume they are more prone for atonic PPH. VBAC can be offered in cases of one previous LSCS, and that LSCS should be a term LSCS, not a preterm LSCS, and also the inter-pregnancy interval should be more than 2.5 years. So if shorter inter-pregnancy interval and not preterm cesarean section, VBAC should not be given. Now postpartum complication, as I already told you, there is 18-fold increase in postpartum hemorrhage in cases of multiple pregnancies due to over distension of uterus, due to multiparity, large fetus and hydramnios. There may be wound breakdown, there may be higher incidence of endometritis, 43% increase odds for moderate to severe depressive symptoms in the mother because of sometimes she is unable to take care of the multiple babies, she has to be awake and she undergoes severe depressive symptoms. So you have to counsel in advance and then you have to take care of postpartum psychosis in these women. Now selective reduction or termination. Now the selective fetal reduction can be offered in higher order pregnancy, like in triplets we very often convert them to twin because of the complications being lesser. So fetal reduction, and you have to mind it that this can be offered only to diamniotic dichorionic, because if you do it in monochorionic then obviously the complication of surviving twin is going to happen. So the fetal reduction can be offered early pregnancy, between the safest bet is between 11 to 13 weeks. Why? Because you can do a nuchal translucency and you can find out which fetus to reduce, and it also improves the survival of the remaining fetus. If you do late intervention sometimes is offered, as we discussed, in cases of TTTS, TRAP syndrome, where you see that there are specific complications, then we can offer the late termination. Now, how do we terminate? How do we do a selective fetal reduction? We do it most easily or accessible fetus. We do a nuchal translucency and select the fetus which is abnormal or which has to be reduced. There are two methods described. You can do transcervically or you can do transabdominally. Different schools they prefer the approach. Both of them can be safer. In transcervically you have to do generally between 9 to 11 weeks earlier. So the people who are protagonists for abdominal reduction, they say that if you are doing an early termination, the nuchal translucency cannot be done, so you are not sure the fetus you are reducing is normal or abnormal, so you may reduce a normal fetus by doing that. So you should wait for 11 to 13 weeks, and when 11 to 13 weeks it is safer to reduce abdominally. So around 22 gauge needle is introduced into fetal thoracic cavity and about 1 to 2 ml of KCl is instilled intrathoracic, and you observe asystole. It should be observed for about 1 to 2 minutes. After that you take out the needle and you rescan after 30 minutes, as sometimes reactivation can occur. However, a repeat procedure is not recommended the same day. We ask the patient to come maybe after a day or two. But if you have observed that there is no asystole, after 48 hours we call the patient again to confirm that the fetal reduction has been successful. There is about 1 to 2% risk of abortion and also the probe. Why? Because there may be leakage of the amniotic fluid from the puncture site. Although in most of the cases, sometimes the seals down. So by doing bed rest, you explain the patient that if you do bed rest, sometimes the needle puncture is very small and it spontaneously seals. However, you have to explain before doing this procedure that there is a procedure related loss of about 1 to 2% as compared to 30% loss if they continue triplet or higher order pregnancies in future course. So every set of twin you see and you wonder that how many times she underwent IVF, IUI or clomiphene for ovulation induction. There is ASRM committee opinion 2012 which says that this is the guideline that how many embryos you should be transferring, and as per all these guidelines, the guideline says that you should not transfer more than 2 embryos in any case, and most of the international guidelines says that if the maternal age is less than 35, if you are transferring cleavage stage embryo in IVF, it should be between 1 to 2, and if you are transferring blastocyst, that is the 7th day embryo, it should not be more than 1. And if the maternal age is more than 35, they have allowed 2 embryos at cleavage stage and 2 at the blastocyst. And at any age, they do not recommend more than 3 embryos if the age is 40 and above, because at 40, beyond 37, if you are doing a pre-implantation genetic screening of the embryo, then if you are screening those embryos, then aneuploidy screened normal single blastocyst is recommended to be transferred. Now, when we see this patient, as in any case, history taking is very important. Obstetric history, the maternal age, parity, mode of conception, like whether it is spontaneous, ovulation induction or IVF. Hyperemesis is a very good clinching factor. If in early pregnancy mother comes and says, doctor, I have severe vomiting, you do a beta HCG, see the levels are very high, this is the first suspicion that she may be a twin pregnancy. Then you may have to look at if the mother is anemic, she has early hypertension. If you have not done an ultrasound, then the early ultrasound will pick up early multiple pregnancy. Also look at the chorionicity, and then you will see all the complications happening in her, as you see the higher incidence of hypertension, diabetes and other twin specific complications. In other history taking, as we said, that oral contraceptive intake has some correlation, because if your patient has been long-term OCP, then there is a rebound increase in FSH which may lead to multiple pregnancy. Family history is important, and prior twinning. If she has a history of prior twin pregnancy, then she is at a higher risk of twin pregnancy. If there are any questions, I will be very happy to answer them. Thank you very much. Any questions? No? Everything understood? I can't see any, where is that person gone? There, from the chat box, if they can you call him? You are 8th semester student? 3rd semester. यहाँ से चैट बॉक्स से देखिए कोई बच्चा कोई सवाल पूछ रहा है. आप लोग को समझ में आया? थर्ड सेमेस्टर को समझ आ गया? ओ अच्छा, ओके, एमडी स्टूडेंट्स है। ओह आई एम सो सॉरी, आई थॉट 8th सेमेस्टर। नो नो, व्हाट आर योर नेम्स? आई एम सो सॉरी। मास्क हटाओ, मास्क में पता ही नहीं चलता। अच्छा दीक्षा, आप? शारदा, बोथ आर इन यूनिट 1। ओके, दिख रहा है कोई बच्चा सवाल पूछ रहा है?
नहीं, अभी तो कोई नहीं पूछ रहा, मैं इधर ही पूछता हूँ।
बंद कर दो, फिर नहीं पूछ।